Good afternoon, everybody. Hello, and thank you for joining us for today's special webinar hosted by the American Lung Association and sponsored by Memorial Cancer Institute. Today, you will hear from the Medical Director and Chief Scientific Officer of Memorial Cancer Institute, who will share information on evaluation and monitoring of incidental detected lung nodules and how it can help diagnose lung cancer at earlier stages when it is most treatable. We are glad to have you all tuned in today to hear about this timely topic. In a moment, Dr. Raez will present some great information and answer some of your questions. My name is Alejandra Navas. I will be moderating and participating in today's session. Before we begin, there are a few housekeeping items to cover. Firstly, this webinar is being recorded and is streaming live on Facebook. Today's session is meant to be interactive, and we want to hear from you. To do this, put your questions in the chat box for those tuning in via Zoom and in the comment section for those tuning in on Facebook. Thank you to those who have already sent in your questions. Our panelists will be answering them shortly. Finally, if we're unable to answer all of your questions, we will send out a follow-up email with answers. Facebook listeners, check the comments for instructions on how to send us your email to be included. Now, I'd like to introduce our speaker, our presenter, Dr. Louis E. Raez. He is the Medical Director and Chief Scientific Officer at Memorial Cancer Institute. Dr. Raez specializes in treating patients with lung cancers. A critical component of his work at Memorial is cancer research. Dr. Raez designs phase 1 through third phase of clinical trials with new chemotherapeutic agents and combinations, as well as translational research in the areas of immunotherapy. His research has been funded by the National Cancer Institute and by the pharmaceutical industry. Dr. Raez teaches the next generation of oncologists as a clinical associate professor of medicine at Florida Atlantic University, Florida International University, and is a visiting professor of medicine at Cayetano Heredia University in Peru. Dr. Raez is active in many medical organizations and gives oral presentations and lectures during national and international meetings in the US, Europe, Africa, Latin America, and Asia. Currently, he is in the international chair of the ISLC Latin America meeting, LALCA, since 2014. Chairman of the Miami Best of ASCO since 2014, chair and founder of the Miami Cancer Meeting, MCM, since 2002, and co-chairman at the Puerto Rico Fall Cancer Symposium, FCS, since 2010. Dr. Raez is board certified in internal medicine and medical oncology. He is board eligible in hematology. Prior to joining Memorial, Dr. Raez was an associate professor of medicine, epidemiology, and public health, and a co-director of thoracic oncology at Sylvester Cancer Center, University of Miami for 10 years, from 2001 to 2011. Thank you, everybody, and Dr. Raez, the floor is all yours.
Hi, good day, everybody. Thank you for the introduction. We are very happy again collaborating with the American Lung Association, trying to teach and learn together more about lung cancer. Today, Alejandra said, Maria said, we're going to talk about lung cancer screening and the challenges that we have about that, you know. First of all, lung cancer screening is not something very popular. It's not as popular as mammogram or pap smear. I guess there are many factors. Now, as you know, there is a stigma for lung cancer patients that we are doing for more than 50 years. There is not a very sympathetic cause, you know, especially for the high amount of smoking that were before. But even like that, there is a lack of knowledge about the importance of lung cancer screening. And this is like, that's a summary of the story of lung screening, you know. So we, all the primary care doctors can tell you that the chest X-rays don't work. It's not the same as the mammogram. The mammogram works, it's a good screening tool. For us, our tumor is in the chest, and we are doing chest X-rays for more than 50 to 60 years, and we already know that doesn't work. The sputum cytology, we used to think that we can diagnose lung cancer in the sputum. It's also negative. Finally, the difference came when we talk about the CAT scan, the chest CAT scans, the computer tomography of the lungs that make a difference. And that's why education is important about that. This is the typical study that all of us know about it, the Mayo Lung Project. This project it was a very famous study of 9,000 people, and it was trying to prove what I mentioned before, that let's do a chest X-ray every year, so we are going to diagnose more lung cancer, and we're going to use also sputum, so hopefully we can use this like the mammogram. And as everybody knows, the lung cancer study was not successful, it failed. And for that reason, we have this idea that, oh, you know, there is no screening for lung cancer because chest X-rays don't work. What we need to learn is about the National Lung Screening Trial, you know, we call it sometimes NLST. This was published in 2011, so that's why this is the responsibility that we have, you know, when there is no information, we cannot do anything about it, but now since 2011, we have this publication in the New England Journal of Medicine. This is a very important study. This is the largest study in the world, done here in the United States. Yeah, 53,000 people, not patients, people with high risk of cancer, usually heavy use of tobacco. Yeah, they were enrolled in this study, and they had 3 annual screenings, and they were followed for 6.5 years. You know, and, to make the story short, what you have to remember is that the only one thing you need to remember from this talk is that we decreased the lung cancer rates between 16 to 20%. This was a successful study. We decreased the lung cancer rates by 16 to 20% if you get a complete tomography of CAT scan on the chest 3 times during 5 years if you smoke. So that is thing to remember. Summary of the smoke. And these are the results of the study. We want to be a little bit, we want to go a little bit deeper. We did this, we call it low dose CAT scan in 26,000 patients, and we did a chest X-ray in another 26,000 patients. Despite the fact that the patients and doctors didn't feel comfortable doing placebo, doing nothing. That's why we put them a chest X-ray as a control. So at least it's better than nothing. And even like that, doing chest X-rays that were able to find they were able to find 900 lung cancers, as you can see there, 941. The CAT scan, the low dose CT, was able to find more lung cancers. And for that reason, you can see that the number of deaths is 20% less. 20% less deaths if we diagnose lung cancer with a CAT scan instead of, you know, chest X-ray. And you can see here, this is the survival. You can see the number of deaths. Now you see the deaths with chest X-rays in the red are higher than in low dose CT. So this is what we need to remember. After the study was published, the USPSTF, the U.S. Preventive Service Task Force, this is the federal agency that gives us the guidelines to do mammogram, prostate cancer screening, colon screening, pap smear. They, for first time in history, they put this guidance. If you are between the age of 55 and 80, if you have at least smoking 30 packs per year, and you are already still smoking or you are quitting the last 6 years, pretty much you are eligible for the screening. And we should do a screening based on the results I just showed you. Okay, and then the criteria changes because I want to show you all the slides why it was important to change the criteria. So with this criteria, I just mentioned to you, okay, 55 to 80, more than 30 years of smoking, we think that there is 8.6 million Americans eligible. So 8.6 million Americans supposed to be screened every year, 5.2 males and 3.4 females. Okay, and we will say 12,250 lung cancer. So we will say 12,250 people from lung cancer death. We do this. Okay, so the idea is to sell 12,000 people. Okay. The problem is that the screening was not very effective. And one of the reasons is because the minorities don't qualify for this screening criteria. That is why you can see that the guidance on the bottom of the slide changes. Because if you can see that paper and photo from Aldrich 2019, 32% of African Americans who develop lung cancer will be eligible for screening. So only 32% of them, African Americans or Black people that develop lung cancer is eligible for screening, meaning the other 68% of Black population don't benefit from the screening because they don't qualify. These guidelines that I have written don't apply to them because don't smoke or don't have an age, etc., etc. That is why we change the guidelines, and the current ones are in the bottom. Okay, if you have age 50 and 80, or only more than 25 smoking, and you quit in the last 15 years, you qualify. So the idea was to enroll more Black people and Hispanics that also don't smoke to the same degree as white population. With this American study, the largest in the world, very successful, there were still a lot of people that didn't believe in screening. That's why it's taking forever to be adopted in the United States. So this second study is very important because even in Europe, they didn't believe us because it was only an American study, only American population. So this Nelson is the European study. In this European study, it was 15,000 people that were randomized between CAT scan versus nothing. So no screening, standard of care, what we do now. And the patients were evaluated at baseline, 1 year, 2 years, and 5.5 years. And they follow them for 10 years, okay? The detection rate was 3% for lung cancer, but the most important thing is this one here, okay? If you see in red, there is a 26% decrease in mortality since the cancer in males, and there is a 39% benefit in females. Do you remember the American study was historical, creating the idea that we need to do screening for a 20% mortality difference. Now the European got 26% benefit in males and 39% in females. So the benefit is even larger than we saw in America. That is why now everybody in the world, based on these two studies, believes in screening. What happened? Despite the fact that we have these two important studies published, as you can see in this graphic, between 3 to 10% of people in the United States get screening, compared with 76% having a mammogram, 74% of screening, 67% have colonoscopy. That is, we really have a crisis now because we are not screening the people who are supposed to screen. With the new criteria that we need to expand the number of Black people and Hispanic people, we should screen 15 million. Okay, so our challenge is to screen 15 million Americans. We are only screening less than 10%. Yeah. So that's why we need this type of talks and education, notification, awareness to increase this rate. Otherwise, there is no benefit. If you want to know more about why this population of minorities don't benefit, I quote this study of Olafagasti that is here from Western Miami, in Florida. If you see all the way in the right side, you can see, to make the story short, that only with the USPSTF criteria in the right column, that was the official criteria that was established in the beginning, only 38% of African Americans qualify for screening, and only 20% of Hispanics. You know, remember, Hispanics smoke, but they don't smoke in the same amount of native population, First Nations, and even white population. That's why it was important to increase the criteria, because until 2021, as you can see in this presentation, the national meeting, very few minorities were benefiting from screening, and that is 40% of the population of our country. Talking about the screening, we're fortunately now we have more than one program. So we have now a second program in the right called Incidental Pulmonary Nodule. Okay. Basically, I already explained about lung screening. So you go to primary care, the primary care identifies that you are consuming tobacco and you qualify, you get a prescription and you get your CAT scan in the left picture. But in the right side, we have another one called incidental pulmonary nodule, meaning, for example, in the Memorial Center system here in Broward County, Florida, we do 300 CAT scans of the chest every week because we have 6 big hospitals for incidental reasons. For example, we have a car accident, you are a senior person that has a fall, then you come with chest pain, we have a trauma, many other reasons, you know. So the people get CAT scans done for many reasons other than cancer. And usually we find pulmonary nodules that are going to become cancer, but nobody puts too much attention because everybody's worried about the heart attack, the trauma, the shooting, the car accident. And so once the patient survives all of these situations, everybody's happy and they forget about the nodule. And that nodule is going to become cancer in 2 or 3 years. And that can be a life-saving situation if we do something before that. So this is an example on that very large public health system, Baptist Tennessee, that they cover 3 states. This is a very rural population, community, very similar to the one that we have in Broward. There were 13,000 patients, and they started to do this incidental pulmonary nodule, meaning reviewing all of these CAT scans that were done for other reasons than cancer. As you can see in the right side, clinical stage, they catch 48% of the lung cancer they diagnose when it's stage 1. Usually, in the real life, lung cancer is diagnosed at stage 3 or 4 because nobody has symptoms until it's delayed. For that reason, it's very hard to cure. But thanks to this program, the low dose CT that I explained, and this one, that is checking pulmonary nodules in the hospital, you can see how there is a shift. Now we are diagnosing half of the patients stage 1 that is curable by surgery or autoimmune. And these are the procedures that were done, and this is the criteria, and this is the survival. You know, so thanks to be diagnosed in stage 1, these patients have a 1-year survival of 76%, meaning that they have very few deaths in this group. So it's totally different to the survival in real life, because as I said, most of the patients in real life are in stage 4, stage 3, and a lot of them die in the first month. So that is why we make a difference diagnosing these patients early. Okay, so I want to make this short and go to the home point. So basically, lung screening is suboptimal because, you know, we have like an average of only 4% compared with mammogram, colonoscopy, pap smear that in the 80s. The current screening guidance that we just reviewed do not favor minorities because they are based only on tobacco. And I also forgot to mention that there is 30,000 Americans every year that they get lung cancer that don't have any exposure to tobacco or any smoking in their lifetime. That's why only this tool is not the only one that is going to help us in lung cancer. We need to develop other tools for the people that don't smoke because this tool is based on smoking. And this new program, the IP and Incidental Pulmonary Program, while instead of be waiting for the patient to come to us with a prescription for the primary care, we actively go to the radiology of the hospital or community center and review the CAT scans of the patients that have had a car accident, chest pain, or other reasons. We can identify earlier lung cancers that can be diagnosed earlier, and we can save more lives. And we need more support and funding to do this. We need more help from the government. As you know, the lung cancer community don't get the same federal funding that other cancer communities. But also, at the end, as I mentioned in the last paragraph, education and advocacy can make a difference. You know, you see here that we are here since the American Lung Association. If we tell you that you need lung screening, even if your doctor forgets about that and you consume tobacco, you can tell the doctor, I need my lung screening. If you have an accident and you go to the ER and get a CAT scan on your chest, please be sure that in the report there is no mention of any nodule or anything that can become a cancer in the future. But there is a lot of importance to be active, very proactive, because we can help also ourselves and we can help our community. We cannot expect the government to do everything for us. That's why we are here. And again, thanks to the American Association and the Modern Healthcare System for putting together this program for the community. And I'm going to stop here because I want to have a chance to answer questions from everybody.
All right. Thank you, Dr. Raez. So I've been receiving some questions, and I'm going to get started. Also, if anybody, as I mentioned earlier, if you have any questions, feel free to put them in the chat. Now, I am going to, hold on one second. The first question I received, if someone is determined to be eligible for the lung nodule program, how long will they be in the program and how often is the testing?
Yeah, this is very important. A lot of people comes from a CAT scan. You know, the primary care tells you that you are eligible for screening, and or you tell the primary care, please write my CAT scan order. But this is supposed to be a program. Look at the mammogram. You know, the ladies don't do mammogram once in a lifetime. They come every year for mammogram. It's the same thing. You know, this is a program. When you come for your CAT scan, and we give you the good news that you are clean, doesn't mean that you can forget about us. You know, we have programs, so you need to register in the program. So in the next year, even if you forget, we will call you and remind you that you need to come for your next screening. So that is why this is a program, and we need your help because there is a problem with compliance. We get a lot of patients screened one time only, and they do not come for follow-up.
Thank you, Dr. Raez. If someone was exposed to secondhand smoke for decades, should they consider getting self-paid lung cancer screening even if they don't meet the criteria?
Yeah, we know that the exposure to tobacco secondhand is probably as important as first hand. If your spouse or your partner has been smoking for 20 years, it's the same as you have been smoking for 20 years. So that's why if the insurance doesn't pay for that, they don't want to pay for that. Here in South Florida, you know, I was the president of Florida Society of Oncology. I'm very proud to say that all the cancer centers, public or private, academic or community, we are very conscious about that. You know, next to Miami, Cleveland Clinic, Memorial Health System, Mount Sinai, our health, all of us have programs for like $90 or $100 to cover the screening. So you can pay cash that amount of money, and we will do the screening for you, and we will enroll you also.
Thank you. Does a CT scan pose any risk to the patient, like exposure to harmful radiation?
Yeah, that was a concern because they said it's radiation, but what happened is so radiation exposure is true, you know, it's a hazard, it's a danger for humans. But you need to remember the worst radiation exposure that we get is from our own sun. We're exposed to the sun every day. Some of us take a lot of planes multiple times a year, and the radiation exposure in the plane is even much higher than downstairs here. So we get exposed to radiation to many different ways. The amount of radiation that you get from the CAT scan is very, very minimal. I don't know if you heard the word that I use, low dose CAT scan, because these CAT scans that we do from the screen are only 20%. 20% of the dose of radiation that you get in a regular CAT scan that you do because you have belly pain, you have headache, or you have chest pain. Once that you are sick, we do a regular CAT scan. But remember, these CAT scans that we are talking about here are for healthy people. Healthy people that has a high risk of cancer, but we don't know if you have cancer or not. That's why we are very conscious that we cannot use the radiation. We don't want that. That's why we call them the low dose CT. 20% of radiation of any other conventional CAT scan you have done in your lifetime.
Thank you. And I know we have low dose CT scanning here at Memorial in various locations. So thank you for that. It seems that some incidental lung cancer findings stem from minor symptoms mistaken for other ailments. Are there any symptoms in particular of lung cancer in those earlier stages and that should encourage someone to get a lung CT scan?
Yeah, no, that is the problem, you know, that the lung cancer doesn't give you any symptoms. When the lung cancer gives you symptoms is when you are metastatic and stage 4. You know, when you have bone pain, or you have a belly pain, you have headache, it's usually from the metastasis. You know, the lungs are very large organs, and when we have nodules or small masses growing in our lungs, we don't feel anything. We don't feel anything. That's why we cannot wait to feel something to be screened. When we feel something, it's probably too late. That's the importance of good screening. You know, you see the criteria for screening. If you are a more than 50-year-old, you have a risk because people get cancer as we get older. If you have smoked tobacco for more than 20 years, you have a risk. If you are still smoking or you just quit recently in the last 15 years, it's not a risk. So that's why, you know, you can be totally healthy and we can still diagnose some cancer.
Thank you so much. Another question we got is, you mentioned that low funding impacts research for screening methods. With increased funding, what kind of developments in lung cancer screening, like an expansion in the age criteria and the PAC per year eligibility, how would it be affected? And this will make it covered by insurance?
Yeah, that was a big problem. You know, insurance only is covering the lung screening for the last 5 years or something like that. You know, I showed you the study that proves that screening is valuable from 2011. And from 2011 until 2019, for 8 or 9 years, no of the insurance plans, not even Medicare covered screening. So we wasted like 8 or 9 years. And every year we could have saved 17,000 lives, you know. So that's why we need more federal and state help, because we need to promote the screening. You know, everybody is very conscious about mammogram, papill, colonoscopy, but nobody knows too much about lung screening. And you see, we are very. I have a lot of admiration for the colon cancer community of advocates. They are fighting hard to go from 75 to 80 in the next 5 years nationwide, and they do a lot of events. We are even less than 10%. So, you know, we are like way below. And I don't know what we need to do to reach 75%. If it's going to take another 30 years or 40 years as it took for the colon cancer or mammogram, that's not acceptable. Remember, we lose 14,000 patients a year while we wait for this. We cannot continue like that because these are people that can be saved. Okay, one thing is that we cannot save some people because you have a pancreas cancer, which is curable, but you're talking about here patients that can be saved with a simple lung screening. That's why we need more help for education. We need more help with the primary cares. Primary cares need to be more aggressive and identifying patients. They also need more resources too. They are very busy. They maybe need nurse practitioners or people that can help them to do programs. And we need to offset also the cost. You know, if the patient doesn't have $100 to pay because he doesn't have insurance, we need to protect the patients and find a way that they don't have to pay for this, you know, because we know that it's an intervention that in the long term is going to save their lives. And actually to treat a stage 1 patient with a simple surgery that makes cure instead of giving palliative chemotherapy for 3 or 4 years, is a lot of savings for the system, for the healthcare system nationwide. So it's not a bad idea to invest in lung screening, or we would invest less in chemo that is not cure patients.
Thank you so much, Dr. Raez. All right, everybody. Well, that's all the time we have for today. But for the questions that we weren't able to get to, please make sure you send those to the email provided in the chat. Nicole will be putting the email in the chat. You'll receive a response in the upcoming week or so with answers to your questions. Thank you again, everyone, for attending today's American Lung Association's Communities Connection webinar. Have a great afternoon.
Yeah, thank you for the invitation.